Welcome to the Hair Loss Show. Dr. Russell Knudsen and Dr. Vikram Jayaprakash discuss issues relating to hair loss and the medical and surgical treatment of hair loss in both men and women.
Hi, I'm Dr. Vikram Jayaprakash.
I'm Dr. Russell Knudsen.
And welcome back to the Hair Loss Show. Thanks again for watching, and please remember to like and subscribe to the channel. It's great to be with you today, and in today's episode we want to talk about, well, if, poor surgery. Now, we're not trying to ridicule poor surgery or from that perspective, but we want to talk about specifically what are the strategies that we have to manage patients when surgery's not gone, as they'd hoped for.
Yeah, absolutely, and unfortunately we do see that, and we've always seen it in the field. Not everybody comes to you with a good result when they had a procedure. Primarily, it comes down to a small range of problems. Typically, the first range that we see is poor hairline design, which is critical because if the hairline design is poor, it draws attention to it. And that can be either the position of the hairline or the angulation of the hairs. The hairs could be heading in the wrong direction, which is really quite a weird thing to do. So we do see that occasionally, and that really, if it's too low or it's poorly designed or the direction's wrong, it has to be removed.
But also, to that point, it could also be poorly designed from a long-term perspective.
Well, we'll get to that as well, about it being too low and the consequences of it being too low.
For later on in life.
For later on in life. So if we stay on the hairline part of it, so again, young patients in particular want low hairlines. They really want, to have no real evidence of baldness, and that's not taking in consideration in their own thought process as to what the consequences are going to be, because the lower you have that hairline, the more grafts it takes to fill it up. Now, we have a lifetime supply of grafts because we don't yet have cloning available to create unlimited donor. We can't do it.
So you've got a limited amount to take from here, and once you run out...
And it's declining. If you've got crown balding, it's not actually just limited, it's limited and declining, because as the baldness spreads, it spreads lower into the scalp, and that restricts even further the amount of donor that might be available to you over your lifetime. So the more you put into the hairline as a young man, the less you have to put elsewhere later on if you need it. So that's the problem with hairline designing. So it can still be a proper hairline in terms of angulation, but still be a poor decision long term, because if you lose a lot more hair, it might have been useful to use those hairs somewhere else rather than have it quite so low. So we like to have that mature look to it, because the way I explain it to patients is, it's got to look good now. We're trying to make you look less bald. We're not trying to make you look not bald. But as you get older, everybody around you's hairline's coming back, and you're becoming mainstream then. And so it's age appropriate at any age.
And that's the thing, because I think we're seeing a lot of people in a younger demographic who are losing their hair, who are coming in and seeking consultation and advice earlier, which is great if they're trying to prevent more hair loss. But one of the problems with that is that if they're looking at recreating a hairline, then their memory is not too distant of what their hairline was when they were 15, and that then becomes the norm that they're trying to achieve. Or
they bring a photo of a celebrity in with like an Italian male model with a hairline that's 5.5 centimeters off the mid eyebrow. Just to reiterate, the average is 7. Right, if for adult males, its average is 7 here, and on facial balance, the lower third should roughly be equal to the upper third. So both women and men actually come in asking for really low hairlines all the time, and you have to explain to them the consequences of that. But it distorts facial balance. It uses a lot of grafts. It could be used somewhere else. There's a whole bunch of reasons.
And I know when I was seeing, we were doing consulting, there's this constant battle. They're trying to pull us down. We're trying to pull them back up in terms of deciding where that height of the hairline is. And it's not because we want to determine what their facial appearance looks like. It's just that we want to have a long-term view of potential further loss.
And the other thing I say to them is it's easier for us to lower your hairline than to raise it.
Yes.
Right, because we can just add grafts a little bit later on if you feel like you want a little bit of fine-tuning, which we do a lot. But otherwise, we've got to take it all out. And the problem with taking it out is that you potentially leave some little punctate scars in the forehead from where you removed the grafts that may have a little bit of visibility.
Yeah,
so
it's
if we have to do it, we do it, but it isn't ideal.
So when you, if you see someone who's got a hairline that's, well, let's just say the angulation is incorrect of some of the hairs, then potentially what you could do is look at extracting, if there are not too many of those at the frontal hairline, extracting some of those and potentially
and reorientating them correctly. Exactly, and that's certainly, I call that repair.
Yes.
Right, because you are altering the characteristics of the graft position. So
I think all of these,
repair.
I mean, my feeling is that all of these sort of repair work that we do is more camouflage than actual, repair in its strictest sense. Because if it's done badly from the get-go, then it's really difficult to correct.
Well, that's right, because in the hairline, if you angle more acutely, you get a shingling effect. And this brings us back to a constant theme that we have to reiterate to the patients, is that when they say, well, will I have the same density as where I've got no balding? And the answer is no. Numerically, that's not what we're trying to achieve. What we're trying to achieve is cosmetic density, which means that because we don't have an unlimited donor supply, we need to find out how to put a certain amount of hair into there to make it look thick enough to diminish the contrast to the surrounding areas and make you comfortable with it. And that is not operating at normal density. And this comes back to one of the trends that we're seeing with a lot of the clinics in Australia and particularly around the world, where they're offering 5,000 graft operations. And the problem with that is that you're using like 2/3 of your donor area in these young patients, giving them massive densities, not taking into account any of the problems that will be associated with further hair loss down the track.
And so that then comes to the next point, which is, when you're saying, well, hey, correct, if you've been in a situation where the initial procedure was harvesting a lot of your donor hair, the majority part of your donor hair, then you've got very little left in reserve to do any corrective work. And if you were to lose any more hair, to try and camouflage that aspect as well. So you're really painting yourself into a corner.
That's right.
If you do, go really big at the beginning and it's not done properly.
So I mean, I and you, of course, make no apologies for being conservative about this, because like I've been operating since 1984, so I can see the consequences of this. It's nearly 40 years ago I started operating, so I get to see the long-term thing. And a lot of the clinics these days have this short view of giving the patient what they want. And giving you what you want may be good in the short term, but it may be disastrous in the long term. You need that education, and this is, we come back to this. You need to think this through very carefully. So, how you design it, and take into account. There's a big difference between patients in donor density as well. We see that a lot. So, just because you only have a certain amount of baldness on the Norwood scale doesn't mean you have the same number of grafts between patient A, patient B, and patient C. Because if you have lower density in the lower scalp at the back, then you've got less grafts to play with. And so there's a lot of sophisticated thinking and assessment that's required in the surgical planning to make sure that you minimise the long-term risk.
And I think it's also really important not to go into one of these consults, to hear, there's a real temptation to go, I want to hear them say yes, I want to hear them say big numbers and be satisfied with that, because that may not be in your best interest in the long term.
Well, I've had the experience over many years of quoting grafts for patients, and they've been, say, to another clinic for an assessment, usually with a consultant, to be fair, and they go, well, how come they told me I needed 3,500 and you're telling me that I only need 1,800? And I'm going, because I'm only going to fill up the areas that need fill up. because patients actually ask us all the time to future-proof.
Yes.
So they say, well, this area isn't thin here now, but how about you put some grafts in there so that if it does go bald later on, the grafts will still be there. I'm going, well, the risk-reward for that one's not great because we could damage the existing hairs by operating in a normal density area, and our first goal is not to damage you.
Yes.
And also to save grafts in the donor bank for later on. So no, future-proofing transplants, we only treat what we see, not we imagine what we might see in 10 or 20 years' time.
Yeah, because you will most people will inevitably, if they open Pandora's box of hair transplant, they will have to be open to the concept of coming back again.
Well, I warn them that it's called the first transplant for a reason.
Very good. All right. Well, I hope that at least addresses some of the important issues of that question. I don't think there's never going to be an answer to that question.
No,
but I think
it does come back to the fact that if you're getting resistance from the doctor to using huge numbers of grafts, is a very good reason he's doing that, or she's doing that.
Yes. All right. Well, thanks again for watching. I think that's a great discussion on that topic, and we look forward to seeing you on the next episode.
And thanks for watching and staying in touch.
See you soon.